our next speaker, Dr. Linda Mobula. I was first introduced to Linda during my time in Haiti for reasons that I can't remember. She was introduced to me by someone else because of something I needed to know. So from there, we've sort of developed an email conversation from time to time. And this has been my first time, as it is for her, for us to meet each other. So there's something, for me anyway, very special about the meeting because of the high regard that I hold Linda and her work in. Now, Linda currently works as a public health and infectious disease advisor with the Office of Foreign Disaster Assistance at the United States Agency for International Development. She worked her way up as a medical doctor from her Bachelor of Science in the University of Arizona in 2004, right up to completing her residency in internal medicine at Johns Hopkins Bayview Medical Center. And during that time, her residency in particular, she made multiple trips to Haiti as a medical director for Samaritan's Purse, an international aid agency that's worked extensively in Haiti and in other places that Linda has worked, such as in Greece and in the Philippines and in Sudan and Mozambique and Burundi, and notably, without stealing her thunder, the work that she carried out in the Ebola in Liberia. So we're very grateful for Linda to be able to come, and we look forward to her presentation. Thank you.
Thank you, Roger. Good afternoon, everybody. Thank you so much for having me. I would like to start this talk by acknowledging one of my colleagues, Dr. Natalie McDermott, who's also worked with me in the Philippines, Haiti, and Liberia. And I want to tell the story of several individuals who responded to large-scale epidemics with compassion. And the first person I'm actually going to speak about is Dr. Kent Brantley, whom you might recognize. He was the first American to contract Ebola in July 2014. Both Dr. Brantley and his wife had moved to Liberia several months prior and were working as medical missionaries. When the Ebola response began, he decided to respond alongside with the entire organization, Samaritan's Purse, based in Liberia, and he contracted Ebola. And he has subsequently written a book, and his story has been featured in a documentary called Facing Darkness. And one of his main quotes is, really emphasizes having to choose between compassion or fear. And he encourages everyone to choose compassion over fear when responding to outbreaks. I am actually going to first show you a clip, a trailer from the documentary.
This was an unfolding catastrophe.
The numbers of new cases and deaths are still rising.
Ebola is the world's most dangerous virus.
The disease is out of control in West Africa.
Action was needed immediately.
Altogether, the family member that I lose, 17.
God has called us to care for the dying, to care for those that are suffering.
We can't say we're Samaritan's Purse and not help.
I was confident that what we were doing was the right thing to do.
I don't think I was scared yet. I should have been very scared.
As the epidemic escalated, we were just desperately trying to stay one step ahead.
My phone rang, and Ken Isaacs said one of our doctors, Kent Brantley, has Ebola.
David looked at me and he said, "You too have Ebola."
And then Barbara was diagnosed with Ebola.
There was a high likelihood our team members were going to die.
I don't know how to describe how afraid we were.
But we still went in hour after hour, taking care of the Liberians and taking care of Ken and Nancy.
We're there to save life. We're there in your name. Why?
Despite the fact that things were out of control, we knew that God was in control.
My greatest fear is that I would have to raise my kids alone.
I felt broken. Who was going to take care of my children?
God puts you in places and supplies the strength to deal with.
If they're on our team, they are our blood. No matter what it took, let's get them out.
Time is ticking. Jesus Christ didn't run. We run to the fire. We don't run away from it.
So what is compassion? Compassion is derived from the Latin word compassio, which means to suffer with. And Jesus displayed the ultimate form of compassion by dying on the cross. And this was discussed in previous presentations. And I'm going to quote a few scriptures that display how Christ responded to suffering by displaying compassion. And the first one is from Mark chapter 1, verses 32 to 33. That evening, after sunset, the people brought to Jesus all the sick and demon-possessed. The whole town gathered at the door, and Jesus healed many who had various diseases. The second one comes from Matthew chapter 16, verse 24. If anyone would come after me, he must deny himself and take up this cross and follow me. And the reason why I put that scripture up was because Christ demonstrated compassion over and over and over again by caring for the sick and caring for those that were suffering. And he asks us to pick up our cross and follow him and do the same. And what is the role of compassion in medicine? As a medical doctor, how do you display or demonstrate compassion towards your patients? There's an article that was written by this gentleman whose last name is Adams, and he basically described compassion as being part of a professional competency, but also technical competency, and said that both are required to affect meaningful healing. So it's not just technical skills, clinical skills that one must have to alleviate suffering, but it's also the need for compassion that's required to help patients heal. And therefore, to respond with compassion requires three things. First of all, you must recognize that your neighbor is suffering. You must have an internal response, but that response must lead to an action in order to relieve the suffering of your neighbor. And how does one do this in an outbreak setting? And that's what I'm going to be discussing. So this map is from the World Health Organization. And it's a map of Africa, and it displays all of the outbreaks that are taking place right now that the World Health Organization is responding to or monitoring. And there are currently 57 ongoing events, and when I say ongoing events, this refers to disasters or crises, different crises that are ongoing, whether it's famine, conflict, natural disasters, drought, etc. And there are 49 ongoing outbreaks in various countries. And it's a little bit challenging to see here, but the one in this, so countries that are actually colored in orange are affected by a cholera outbreak. So you have Ethiopia, Nigeria, the Democratic Republic of the Congo, Mozambique, Zambia, Angola, the list goes on and on. There are also a couple of what we call viral hemorrhagic fevers, and that's the family that Ebola is part of. And Lassa fever is a disease that's very similar to Ebola, and there's an ongoing outbreak in Nigeria right now. How do you respond with compassion to all these outbreaks? Let's think about that as we move forward in this presentation. So I want to talk about the International Health Regulation. So this is a legally binding instrument that the World Health Organization uses to to ensure that countries are monitoring outbreaks and reporting cases. And it really exists to keep our world safe. And it was initially developed in the 60s, and it was derived from the international sanitary regulations to curb the spread of infectious diseases like cholera, yellow fever, or the plague. And in 1969, during the 22nd World Health Assembly, the international sanitary regulations were renamed and called International Health Regulations. And I'm going to refer to the International Health Regulations as IHR moving forward. And the last time IHR was actually updated was in 2005, and it was in response to the SARS outbreak in Asia. And there have been multiple discussions and debates about whether or not IHR needs to be revised as a result of the Ebola outbreak in West Africa. And here are a couple of points from IHR. It talks about the importance of preventing outbreaks in order to preserve trade and travel, looking at scientific methodologies to ensure that individuals are kept safe from outbreaks. But also there's a clause that discusses human rights. And I'm going to read this quote from Article 3. It says, IHR implementation shall be with full respect for the dignity, human rights, and fundamental freedoms of persons. And I think this is extremely important. This was added in 2005. Because on one hand, when you're responding to outbreaks, you wonder if it's out of fear, or is it to truly preserve life and ensure that there's not a decrease in mortality. And I would think that we're responding to outbreaks in order to prevent mortality and to preserve human life. And I think this Article 3 from IHR is very relevant in that context. And we talked a lot about disasters this morning and yesterday. And there are multiple disasters that can occur, either natural disasters such as flooding, displacement due to conflict, for example. You can have drought, but this is a list of risk factors that lead to various infectious diseases that can occur among populations that are affected by a disaster. So insufficient water can lead to cholera or other waterborne diseases. Contaminated water, very poor sanitation can all lead to cholera or a risk factor for cholera. Overcrowding can lead to outbreaks of measles and meningitis. Malnutrition is a risk factor for cholera and other diseases. So what is the health impact of complex emergencies? And this graph here focuses specifically on conflict and violence. So when you have conflict occurring in a country, it can lead to displacement. And as a result, individuals lose their livelihoods. And they might have to seek shelter in a camp, and therefore have poor access to water and sanitation, and have to live in concentrated areas in camps. Another effect of a conflict can be collapse of trade, leading to increases in malnutrition, decreased immunization, because people are not getting immunized or receiving vaccines. And as a result, their vulnerability to infectious diseases has increased, and you have proliferation of all these outbreaks and mortality increases. And here are a couple of examples of outbreaks that occurred in the context of a complex emergency. There were several deaths due to cholera in Rwandan refugee camps after the genocide in 1994. That's one example. Another example, which I'm going to discuss in more detail, is the Haiti cholera outbreak. And from 2010 to 2012, there were more than 600,000 cases, with 55% of which were hospitalized, and you had 7,900 deaths. And I'll talk a little bit about what case fatality means and why this percentage is significant as we move forward. Let's talk about Ebola first. So Ebola virus disease was formerly known as Ebola hemorrhagic fever, and it's caused by a virus called Ebola virus. And this was actually discovered in 1976 in the Democratic Republic of the Congo. And there was a simultaneous outbreak occurring in what was then called Sudan. And it was identified after a Belgian nun died in ex-Zaire, which is now called DRC, in 1976. So in September of 1976, in a town called Yambuku, which is in the northern part of DRC, there were many patients that were coming to the hospital with malaria-like symptoms. And when you have malaria, you typically present with a fever, chills, night sweats. It presents as flu-like symptoms. But in addition to those, the typical malaria symptoms, they were actually presenting with profuse bleeding. And this was unusual. And this is the team that actually was able to isolate the virus. And it's composed of many individuals that were part of the Ministry of Health in ex-Zaire. There were Belgian nuns and priests. There were also individuals from, I think, the University of Louvain in Belgium. And they all worked very hard to discover this new disease, which was actually named Ebola hemorrhagic fever. And it was named after a river in ex-Zaire. Since then, there have been multiple outbreaks of Ebola that have occurred, and mainly occurring in Africa. The majority of outbreaks have occurred in Central Africa. So the Democratic Republic of the Congo has had now 9 outbreaks. Sudan has had 3. Uganda has had 3 outbreaks. In December 2013, for the first time, an outbreak actually began in West Africa, in a country called Guinea. And this outbreak spread to Liberia, Sierra Leone, Senegal, Nigeria, Mali. There were also cases in the United States as well as Italy. And I'm not going to go into much detail, but there are 5 subtypes of Ebola, and the most common subtype that you find is Ebola Zaire, which was identified in 1976 in Zaire. How is Ebola transmitted? Typically by direct contact with an individual who's suffering from Ebola, contact with a natural reservoir, which is thought to be fruit bats, contact with infected cadavers. In many of these places, there are cultural burial practices where family members will hug the dead and therefore come into contact with body fluids that are infected. And it is thought that the majority of transmission that occurred in Guinea, for example, occurred through contact with infected cadavers, through unsafe burial practices. There's also a lot of hospital or nosocomial transmission, so meaning when a patient arrives at a hospital and is treated by a physician or nurse, and they're not wearing protection, they come in direct contact with body fluids, and they're able to, therefore, contract Ebola. And it is a terrible disease. I mentioned the fact that patients present with hemorrhagic symptoms, and very often they bleed to death. And because Ebola presents very similarly to malaria, in countries where there has not been an outbreak, a healthcare worker will think it's malaria and they will touch the patient without wearing protection. And therefore, healthcare workers are at increased risk for contracting Ebola. And that was the case in West Africa. Many healthcare workers died. And this occurred in countries where you did not have many healthcare workers in the first place. So how do you respond to an Ebola outbreak? In addition to providing clinical management or case management by treating patients, it's important that patients are isolated to prevent transmission to direct contacts, family members, neighbors. Contact tracing is a method that's used by epidemiologists, for example, to ensure that every single person a patient with Ebola has been in contact with is monitored for a period of 21 days to ensure that when they develop symptoms, they are isolated. And this became extremely important safe burials because of the cultural burial practices that I discussed earlier. So how did this outbreak begin? It all started in Guinea. So Guinea was colonized by the French, and there was a political party in place that was not well received by the southeastern part of the country, which is called the Forest region. So in December 2013, there were cases of individuals that had a fever, diarrhea, vomiting, and hemorrhagic symptoms, so they were bleeding. And nobody could figure out what this disease was. And the government of Guinea decided, you know what, I think it's just a lie. It's not, I don't think this is true. These are just rumors. Elections are coming up. We're not going to respond. We're not going to take this seriously. And so from December 2013 until March 2014, more and more people got infected. And none of these cases were being reported. Finally, in March 2014, a delegation from the capital, Conakry, went to the Forest region to investigate this illness. And they realized that it was actually Ebola. And it took everyone by surprise because there had never been an outbreak of Ebola in West Africa. And I talk about compassion quite a bit. And I talked about direct contact, how individuals come into direct contact with someone who's sick. So imagine having a family member who's ill. What will your response be? I think the natural, compassionate response will be to take care of that family member. And so many family members would take care of their loved ones that got sick, and they would become ill. And the outbreak continued to spread because there was no response or official response to this outbreak. And as I mentioned, all the outbreaks up until 2013 had occurred in Central and East Africa. And all of a sudden, we had cases that occurred in Guinea, in the Forest region in Guinea. And Guinea shares a border with Liberia, which is right here, and Sierra Leone, which is here. And it's important to note that these borders are very porous, so people will cross the border all the time, back and forth, back and forth. And so that's how the outbreak spread to all three countries. And this outbreak was unique because it was unprecedented. In terms of the geographic scope, typically these outbreaks only occurred in very small villages. All of a sudden, you had an outbreak occurring in an urban area where you have high population density, and it began to spread very rapidly. The duration of the outbreak was unique. It would take a couple of months in the past for an outbreak to be controlled. This outbreak took several years. The number of people affected, there were more than 28,000 people that contracted Ebola, and there were more than 10,000 people that died. This is the highest number of deaths due to Ebola that ever occurred. And it required a humanitarian response, meaning multiple countries got involved, multiple governments, and everybody had to change their approach in actually responding because of the fact that there was additional risk for international spread. But it also impacted sectors such as food. Food insecurity became an issue. Less and less people were attending health facilities. So we saw an increase in the number of deaths due to things like malaria or pregnancy-related illnesses. And it created a lot of fear. Created a lot of fear worldwide, actually. And I remember in the US in October, November 2014, there was an election. A lot of politicians used that to create fear and hysteria, unfortunately. And there was a lot of discrimination towards individuals that were African descent that were moving to the US. I know of people that were called Ebola, were given the name Ebola because they were from a certain country. So there was a lot of stigma, discrimination, and fear, unfortunately, but also in the countries that were affected by Ebola. patients with Ebola faced a lot of stigma. And I love this cartoon from MSF. MSF, Médecins Sans Frontières, is a non-governmental organization, and they were the first to respond to the outbreak in March 2014, and they deployed a team to Gekadu, Guinea, which is in the forest region, and they very shortly became understaffed because of the magnitude of the outbreak, and they required additional help. But nobody was willing to respond, unfortunately. In Liberia, Samaritan's Purse had a country office there, and they eventually responded. So under IHR, there is a designation called Public Health Emergency of International Concern. And this designation can only be made by the Director General of the World Health Organization. And it wasn't until August 2014 that this outbreak was declared a Public Health Emergency of International Concern, or PHIC. I will refer to it as PHIC. So imagine from March 2014, when it was first identified, until August 2014, several months went by without this outbreak actually taking, this outbreak did not have much significance overseas, internationally, until August 2014. And in view of the virulence of the disease, potential for additional spread, risk for global health security, and limited and inadequate response capacity, the World Health Organization basically declared this outbreak to be a PHIC. And there have only been 4 PHICs historically. The first one was in 2009 during the H1N1 pandemic, influenza pandemic. The second one was with the reoccurrence of polio. The third one was with Ebola. And number 4 was Zika, the Zika outbreak in South America. And I want to play this video.
This is Meliandou, a small village tucked into the forests of southeastern Guinea. It is home to a few dozen families. It has no electricity and no running water. Here, in December of 2013, a 1-year-old boy named Emile is thought to be the first victim of the Ebola outbreak. By the end of March, 11 people will have died in the village. The boy's grandmother is linked to 2 people from the nearby village of Dawa who get the disease. A relative of Meliandou's midwife takes Ebola to yet another village, Dondu Pombo. It takes about 30 minutes to drive on the dirt road from Meliandou to the largest town nearby, Gekadu. The midwife is taken to a hospital there. In Gekadu, a health worker also becomes ill and is taken to Macenta. Soon after, a doctor dies there. The doctor is buried in Kisidogu. Within weeks, more than 60 people will have died across the region. The outbreak starts at the intersection of 3 of the poorest countries in the world. The area is home to the Kissi ethnic group. There are few official border crossings from Gekadu into the neighboring country of Liberia, but extended families cross easily by foot and dugout canoe. In this part of the world, the few existing clinics and hospitals often lack running water and hand soap. The region had little familiarity with Ebola since nearly all of the previous outbreaks were in Central Africa. Making matters worse, Ebola's symptoms resemble endemic diseases in West Africa like malaria, cholera, and Lassa fever. By February, people connected to the first patient's family are thought to have died in Conakry and in Kekahu, Sierra Leone. This indicates that the virus probably traveled far and crossed borders early in the outbreak. But the first confirmed cases of Ebola in Guinea came only on March 21st. Days later, an Ebola case is confirmed in the capital, Conakry, a city of more than 1.5 million people. Still, reports of new infections decline in late April, a statistical plateau that resembles the historical outbreaks that burned out after a few months. Some international health organizations begin to relax their operations. Meanwhile, weak contact tracing and local suspicion toward foreigners and national authorities allows the disease to spread outside the clinics. Ultimately, the virus resurfaces. In Sierra Leone, unconfirmed cases of people dying in the village of Pondu with Ebola-like symptoms start as early as March, but the first confirmed case comes only in late May. In July, Ebola is confirmed in Freetown, the capital. The patient is a woman living in a Kissy neighborhood of the city. At this point, the outbreak is surging out of control.
So what should the Christian response be to an outbreak like Ebola that's spreading rapidly and killing hundreds of people, thousands of people? And I want to talk a little bit about Samaritan's Purse response in Liberia. So in Monrovia, which is the capital of Liberia, there was no treatment facility for Ebola. So the country director of Samaritan's Purse, Kendall Kaufeld, had a discussion with MSF and decided that it was Samaritan's Purse's duty to respond to Ebola because it was happening in their neighborhood. And they therefore transformed their chapel into a treatment center. The chapel only had 6 beds in June, and the initial intent was to just isolate patients and transfer them to another facility. Soon, they realized that there was a need to actually treat patients. So physicians, nurses were trained, and they began treating patients. And Natalie was part of this back in June and July 2014. This is a picture of myself in the middle, Natalie and another one of our colleagues in the hot zone, high-risk zone of an Ebola treatment unit. So when you're treating patients, this is what you look like. Imagine having a disease where you're hemorrhaging, you're in a lot of pain, and you're suffering. And these are the healthcare providers that come to you and are supposed to comfort you and care for you. How do you do that well while wearing personal protective equipment or PPE? It's very challenging. Unfortunately, as I mentioned, one of my colleagues became ill, or 2 of my colleagues became ill, Dr. Kent Brantley and Nancy Wright-Bull. Nancy was working as a hygienist. She had also moved to Liberia with her husband to be a medical missionary. To be a missionary, not a medical missionary. But Kent and his wife had moved to Liberia to become medical missionaries. And one of the quotes that Kent makes is, "Faith does not necessarily keep you safe." Because of his faith, he was compelled to move to West Africa. And in the midst of that, this outbreak began. And he often wondered, why did I get Ebola? And that's a question that I had as well. Why did all these individuals contract a disease that was extremely deadly? And where is God in all of that? I remember meeting a mother who would come to the treatment unit every day to visit her young son. And she looked at me one day and said, "Please save my son, he's my only son." And she would start praying out loud, asking God to protect her son, and he died 2 days later. And I felt helpless. And I began struggling with the question, where is God in the midst of suffering? So Kent Brantley contracted Ebola, was diagnosed with Ebola on July 26th, 2014. Nancy Wright-Bull was diagnosed with Ebola about 2 days later. And they were both the first human beings to receive this experimental drug called ZMapp, or ZMapp as they call it in Canada. And it was an experimental treatment for Ebola virus disease. And it's a cocktail of antibodies, essentially, against the surface of the virus. And there had been trials prior to this that demonstrated that this cocktail of antibodies was actually effective in non-human primates or monkeys. It had never been administered to a human being. And under what we call compassionate use, it is allowed to provide or administer investigational drugs to human beings if there is no alternative therapy available. And the team of physicians, including myself, that were taking care of Kenton and Nancy, basically decided that we would administer this drug. to both of them. They both received the drug and they survived. The drug was subsequently studied in a clinical trial, and the efficacy was found to be 91.5%. But in thinking about these issues, I mean, you have to think about some of the ethical issues that are related. I think do no harm is an ethical principle and a humanitarian principle. How do you care for individuals in an environment that has limited access to resources in a compassionate way, and how do you prevent harm? And these are very complicated questions. So this is a picture of Kent leaving his house the day after he was administered the drug. He was then transferred to Emory Hospital in Atlanta and cared for by that team. And this is Nancy's house. We treated both of them in their homes, where they were placed under isolation after receiving a diagnosis. So these are just pictures of our ambulance. We had to create a makeshift ambulance where we placed a mattress in the back of a pickup truck, covered it with tarp, and placed pillows and buckets and sent them to the airport where they were then transferred to the United States. So after all of these events, the World Health Organization convened an ethics panel in response to the use of this drug in Monrovia. And they said that it was ethically acceptable to offer unproven interventions that have shown promising results in animal models. And after this meeting, within months, multiple international and academic ethics committees met, and they allowed the use of experimental drugs for Ebola. And I want to take a step back and talk to you about why, personally, the decision to use Ebola aligned with my faith as a Christian, and why it was important for me to think about compassion as a principle as I was treating Kent and Nancy. So I will never forget the day before his clinical status deteriorated, Kent's wife, Amber, called him on the phone, and they have 2 little children. And his 2 little children would sing to him on the phone. And I just kept on thinking, what will happen to him if he dies? This family would be robbed of a father, of a husband. And I personally, as well as the rest of the team, did not want that to happen. So it was really compassion that was the driving factor that led us to administer this drug. But obviously, we had to take into consideration some of the ethical issues and safety issues and the principle of do no harm. And that's extremely important. To make a long story short, the Ebola outbreak, as I mentioned, lasted for about 2.5 years, affected multiple countries. The 3 primary countries that it affected were Guinea, Sierra Leone, and Liberia, which are poor countries. And I think there's a theme that's recurring. We're hearing a lot about poverty. We're hearing a lot about challenges with access to care, access to clean water. So my question is, and we can discuss this during the question and answer session, is, was the Ebola response man-made, or was it God? And I just want you to think about these things. Here's another issue that has come up, a syndrome called post-Ebola syndrome. As if it isn't enough to suffer from Ebola, multiple survivors are now dealing with symptoms due to Ebola. So they actually experience a lot of sequelae, including ocular problems, auditory problems, arthritic symptoms, so fatigue, headaches, short-term memory impairment. The biggest symptom I would say that Ebola patients have to endure is stigma. Stigma from their loved ones, from their neighbors, from their family members. And here are pictures of several survivors that I've had the opportunity to meet in Guinea. These two pictures are from Guinea and Liberia. You know Kent's story. But in speaking with these survivors, one of the main issues that came up over and over and over again was that they were shunned by their communities. In fact, a woman who used to sell her fruit and vegetables at the market was told to never sell her products at the market again, and they would call her Ebola. How does she take care of her family in response to that? And there are many, many stories about stigma. And I'm going to shift gears and talk about Haiti, which is also called Haiti in Creole. It's a land of high mountains. There's a book that was written by Paul Farmer called Mountains Beyond Mountains. And it's based on a Haitian proverb that says, beyond mountains there are more mountains. And when you go to Haiti, there are mountains everywhere. And the population is estimated to be 10 million. And it was actually the first Black republic. And independence was led by a slave revolution. And I believe Bob mentioned this, but there was a debt of 150 million francs after independence. And the French would continue to collect money from Haitians until the earthquake occurred in January 2010. And according to the Human Development Index, Haiti is considered to be the poorest country in the world. So we're hearing another theme here, poverty, over and over again. And I'm not going to go into much detail because this was already presented. On January 12, 2010, Haiti experienced a 7.0 magnitude earthquake, causing more than 200,000 deaths. And I first went to Haiti in August of 2010, so several months after the earthquake, and I volunteered in a small clinic that was located in one of the largest slums in Haiti, called Cité Soleil. And Cité Soleil is considered to be one of the most dangerous neighborhoods or slums in the Western Hemisphere. As Roger mentioned, in October 2010, there was a cholera outbreak. And interestingly enough, the source of the cholera outbreak was actually from soldiers that were from Nepal. So there was a UN peacekeeping mission in Haiti, and this UN peacekeeping mission was actually composed of soldiers from Nepal. And there had been an outbreak in Nepal prior to their arrival, so they introduced cholera into Haiti for the first time in more than 200 years. And I mentioned the number of deaths that occurred in about 2 years, more than 7,000 people. I think this number is a lot higher because I don't think all those deaths were actually being reported. And the recovery from the earthquake and from cholera has been extremely challenging. It's been about 8 years. And I'm sure Pastor Luke will talk to us more about some of the challenges that Haiti is facing due to the earthquake and cholera outbreak. Here's a picture of the presidential palace that was destroyed. This is the cathedral in Port-au-Prince. And I really liked this piece of art. It's basically a picture of a map of Haiti with a tear saying that we need help. And prior to the earthquake, prior to the cholera outbreak, there was already a lot of poverty and there were very weak health systems. This is very similar to what occurred in West Africa with Liberia, Sierra Leone, and Guinea. So these countries that have a lot of fragility, that have high levels of poverty, weak health systems, are really at high risk of suffering from these natural disasters. And what is cholera? It's an acute diarrheal illness, and initially confirmed in October 2010 by the Centers for Disease Control. And the first cases occurred in a place called Artibonite in the Central Plateau of Haiti. And I mentioned these facts. It was the first outbreak in many years, and it was actually introduced by soldiers that came from Nepal. Just overall, there have been 7 pandemics, cholera since 1807, and studies led by Dr. William Greenough, who's a physician at Johns Hopkins, led to the production of oral rehydration therapy. And this is probably one of the biggest scientific discoveries because the use of oral rehydration therapy in cholera reduces mortality very significantly. When patients come in and they're extremely dehydrated, when you give them oral rehydration therapy, they're able to recover quite rapidly. And in 1978, the World Health Organization decided to use ORT as the mainstay treatment for cholera and other diarrheal illnesses. In 2002, it was estimated that 3 million lives were saved due to the use of ORT. This is a child that came into our cholera clinic in Cité Soleil. She was extremely dehydrated. She was very close to death, had symptoms of diarrhea, vomiting. So in cholera, not everybody is symptomatic. 75% of patients that actually have cholera do not have symptoms. But you can still transmit the disease. So imagine not having symptoms, not knowing that you have the disease, but still being able to transmit it. And these are pictures of mothers that would bring in their children day after day, and they would start coming in. This is in October 2010. Sometimes they would walk for hours and hours trying to find a cholera clinic. And we would sometimes have to transfer them to another location in a Haitian taxi, which we call tap-tap. So we basically place an IV line in them, place them in the back of a truck, and send them to another center where they would be stabilized. And it wasn't until the beginning of November that Samaritans First actually set up a cholera treatment center in Cité Soleil where patients would come and be treated, and in another location called Bercy, where patients would also be treated. And this is an interesting picture here because it says ONG, which stands for NGO, or non-governmental organization, plus MINISTA, which is the UN peacekeeping group, is equal to cholera. So many Haitians thought that cholera came from international organizations and the UN peacekeeping mission. I mean, it is true that the source of cholera was identified as having come from Nepal, but due to this, there was a lot of rioting, a lot of fear. So a very similar response to Ebola in West Africa. And I would say that, just personally, it was challenging to treat cholera patients because of the fact that they came in very close to death. And again, wondering, why do these little children have to suffer when it's a preventable disease, easily addressed by hydration, sanitation, improved sanitation, and access to clean water. And I remember speaking with patients sometimes, and I would say, how are you? Comment vous in Creole? And they would say, oh, tout va bien, par la grâce de Dieu, which means everything is going really well by God's grace. And I would think to myself, you know, if I had cholera, and if I were lying in a cot, I probably wouldn't say that all is well. And so here's that resilience that comes up again. And the fact that they're not turning away from God, but they're embracing God, as Roger pointed out. And lastly, I just want to talk a little bit about Henry Dunant, who's actually the founder of the International Federation of the Red Cross. He came from a very large family of Swiss bankers and happened to be in Austria, I believe, where this battle was taking place between the French and the Austrians. And there were many, many casualties that occurred as a result of this battle. And he realized that those that were being affected by this conflict were not receiving the assistance they needed. So he took it upon himself to gather supplies and to start administering aid to those that required assistance. And he did it for both sides of the party, both sides of the conflict, both Austrians and French soldiers, without discriminating against one side or the other. And as a result, IFRC actually developed a code of conduct consisting of what we call humanitarian principles. And some of these principles are principles such as humanity, neutrality, impartiality, and are considered by humanitarian organizations when they're providing humanitarian assistance. And going back to compassion and those three components of compassion, recognizing those that are suffering, having some type of emotional reaction, emotional resonance, but then the third part, movement towards addressing suffering. And I think as Christians, as believers, whether you're a believer or not, I think as part of the Christian faith, it's important to consider the third part. What will you do in response to those that are suffering? And I want to end by reading a story about the Good Samaritan in the book of Luke, chapter 10. And Christ is having a conversation with an individual. And this individual asks Jesus, "Who is my neighbor?" And Jesus tells this story. A certain man went from Jerusalem to Jericho and fell among thieves, which stripped him of his raiment and wounded him and departed, leaving him half dead. And by chance, there came down a certain priest that way, and when he saw him, he passed by on the other side. And likewise, a Levite, another religious man, when he was at the place, came and looked on him and passed by on the other side. So two individuals that have a religious background that saw this man that was suffering and just walked by. But a certain Samaritan, as he journeyed, came where he was, and when he saw him, he had compassion on him. And this is the important part. He didn't stop there. He went to him, bound up his wounds, pouring in oil and wine, and set him on his own beast, and brought him to an inn and took care of him. The next day he departed, took out 2 pence, gave them to the host, and said unto him, "Take care of him, and whatever you spend, when I come again, I will repay it." Which of these three was a neighbor unto this man who fell among the thieves? And he said, "He who showed mercy on him." Then Jesus said, "Go and do likewise." And I think that's what it means to have compassion, is to act the same way the Good Samaritan did. And when you see somebody who's suffering, to not just ignore the person, not just have this emotional resonance thinking, okay, I do feel bad about what's happening, but it's to do something about it. And this scripture encouraged me during the Ebola response, and it's from Psalms 10, verses 17 to 18. "You, Lord, hear the desire of the afflicted. You encourage them and listen to their cry, defending the fatherless and the oppressed, so that mere mortals will never strike terror." Sometimes we're unable to show compassion to those that are far away from us for various reasons, or those that we can't show compassion to because we have personal protective equipment. But God does hear the cries of the afflicted, and he does provide comfort to them. And I want to end with this. After the Ebola treatment unit in Monrovia was dismantled and disinfected, one of our friends was able to take this picture. An Ebola patient wrote on the wall, "God is with us in here." So in response to the question, where is God when people are suffering? He's right there, he's right with them. And this was a very big source of encouragement, because I realized that God was with Ebola patients, even though we couldn't do everything we could for them. God was still with them. Thank you.
Thank you, Linda. Thank you very, very much. It's good to be reminded that we live in this other dimension in a fragile world of our own health. And lest anyone here thinks that this is not particularly relevant to us, the number one threat to the UK still remains a pandemic flu. So be careful, as someone who had it this winter. Anyway, any questions, please?
Linda, you made the comment linking poverty to what you saw. Would you like to comment on the fact that West Africa, those countries, Sierra Leone particularly, are very rich in minerals, particularly diamonds?
Sure, that's a very good question. So Sierra Leone and Liberia experienced a civil war for many years, and they were just in the process of recovering from those civil wars prior to the outbreak. And these countries do, in fact, have a lot of minerals. They have a lot of diamonds. Unfortunately, there is a lot of corruption in these countries. where there is a select few that actually benefit from those resources. In addition, I think governance is a very important factor. You have to have strong leaders in order to make a country stable, and in order to have strong health systems. Because in order to respond to an outbreak, you really need to have a lot of healthcare providers that are well-trained, good surveillance systems to be able to detect the outbreak quickly and respond. So there are many different factors, including the fact that there is poor governance, corruption, in addition to poverty, that have been risk factors and have contributed to this outbreak being out of control. But I also have to say that the international response was very slow. It took several months for the international community to really mobilize and send teams. One, it was due to the fact that there weren't that many people trained to respond to Ebola. Médecins Sans Frontières was probably one of the only organizations that had responded prior to that outbreak, and they were overstretched, which is why Samaritans first got involved. I think in the early days, there was also a lot of fear, given the fact that we call case fatality rate, which is the number of individuals that die, or the percentage of individuals that die out of those who had the illness. That case fatality rate was really high. 80 to 90% of people at the beginning of the outbreak died because of the fact that they weren't able to access care. And that number came down eventually to about 45% in the various countries because healthcare providers were trained and more humanitarians were willing to respond.
Sorry, and I'm going to lose my voice as well. But can I ask about the choice that you made about trying the new drugs on your colleagues? Did you get the opportunity to use those interventions with the other folk that you were treating? And if so, did you have to make choice over that? And how difficult, or who supported you in doing that?
That's a very good question, actually. I actually just came back from Canada about a week ago, and I was able to visit the laboratory that developed this drug and meet the researchers that actually discovered it. And I did not mention the fact that before Dr. Brantley and Nancy Wright-Bull received the drug, there was another individual that was being considered, and he was a physician from Sierra Leone. And he had conducted research on viral hemorrhagic fevers for many, many years. He contracted Ebola, and to make a long story short, the team that was taking care of him decided not to administer the drug to him, and he died 4 days later. The drug was then brought to Liberia in a canoe and handed to us. After Nancy and Kent received the drug, the president of Liberia asked that the drug be administered to other healthcare providers in Liberia. And I think under compassionate use, it was administered to a total of about 25 individuals. I was not involved in that decision to administer the drug to other people. However, I've had multiple conversations about why the first doctor did not get it. And there were lots of discussions about race, because he was African and Kent was American. Was Kent, did he receive more favor because of the fact that he was American? And the reality is no. It was a very complex decision. I was not involved in that decision, but I've spoken with folks that were, and the providers did not feel comfortable administering this drug to someone who was so far advanced in his illness. And if it had been administered to him and he died, I think the ramification would have been terrible. We were lucky, blessed to have Kent and Nancy respond so well, but there definitely was a risk that they would not have responded well to that drug. We were willing to take that risk because at the time there was no other option. But I think careful ethical considerations need to be made when doing that, and there are lots of papers that have been written about the ethics of administering an investigational drug that has not been used in humans. And the only reason why, I think, one of the reasons why this was allowed was because of the high mortality rate. and the fact that there was no cure for Ebola at the time. The researchers who discovered it actually worked on the development of the drug for more than 10 years. And after 10 years, nobody was really interested in this drug anymore because Ebola only happens in Africa, way over there, not in Europe, not in America. So it was put on the shelves, and they were actually doing a stability test to test temperature stability in Sierra Leone when the outbreak started. And because it was actually on the ground in close proximity to where healthcare workers had contracted it, we were able to have access to it. But lots and lots of discussions occurred prior to administering the drug. And it wasn't, I did not make that decision. It was brought in by individuals that worked with the National Institutes of Health, Centers for Disease Control. These discussions took place at a higher level. When I was given the really opportunity to care for Kent, he had declined the drug and said, I want Nancy Rifle to receive it because she's older, she's more sick. All of a sudden, he started deteriorating very quickly. And myself and another physician decided to administer the drug to him. And I gave it to myself. And it was quite intense because I did not know what was going to happen, whether he was going to have an adverse reaction or not. But I think compassion was a thing that was in the back of my mind, and I think that overcame fear. For a lot of us, I think Natalie can talk a little bit about her story as well, and how she also went to West Africa because of the Ebola outbreak. And I think anybody who was there was at high risk of actually contracting the disease, but stayed for a reason, and that was to prevent the deaths of multiple people.
I think Linda's kind of said this, but maybe not in as much detail. One of the reasons that the doctor in Sierra Leone didn't receive it was about consent, and he was so unwell that he could not himself consent to receive the drug. Even though Kent deteriorated, he had previously consented to him and then also spoken with Nancy, and Nancy consented to receiving the drug. So the other issue was that this would have been doctors making a decision for an adult patient who hadn't themselves said they were willing to receive an experimental treatment. So that was a big factor as well in the decision that was made, as far as I understand it.
Thank you very much. Can I broaden out the discussion to something you just mentioned, actually, and I was just thinking about, which is that it is said, and I presume it's correct, that drugs companies in North America and Europe concentrate on diseases, or trying to develop treatments for diseases which may affect small numbers of people in rich countries, like North America, because there's money to be made from that, while neglecting perhaps rather simpler but more widespread diseases in places like Southeast Asia and Africa. It seems to me if that is the case, there's a strong moral issue and ethical issue. First of all, is it your perception that is indeed the case? And if it is, what can be done about it? I mean, I know people like the Gates Foundation are heavily involved in making HIV treatment available cheaper in Africa and so on. But what's your perspective on this from your experience?
So I do agree with the fact that drug companies tend not to work on drugs that affect individuals living in places like sub-Saharan Africa or low and middle income countries. I think the reason why the development of vaccines and drugs was accelerated during the Ebola response was because of fear, because Ebola has no borders. What do you do is a really good question. I think advocacy is really important. Advocacy with governmental donors to really try to get them to focus on developing drugs that are affecting the poorest. And I think it's part of our Christian duty. I think it's a moral imperative to do so. If you're a researcher, I think working obviously on such issues is also important. I met one of the researchers who had worked on this drug for many years, and he had walked away from his faith because of the fact that it was so discouraging to see this many people die And because of the fact that this drug that he developed for many years got shelved. And yet, he describes the entire process as a miracle, because eventually it did get used, and it did save lives at the end of the day. And in his perspective, God gave him the perseverance and the patience to continue to work on this for years and years. And it brings up an interesting point about tools that God gives us as doctors, nurses, researchers, public health specialists, pastors, to address suffering, address outbreaks. I think that we're given clinical skills, we're given counseling skills, we're given skills to do all these things in response to immense suffering. And I think God uses people to do his work.
Any more questions? If not, I've got a few. So keep me quiet. Linda, unless I missed it when I had to take leave for a while, as I understand it, I mean, it certainly was the case with cholera, which you did mention, but also with Ebola. The whole matter of the fear that it created in the localities, the misunderstanding of this disease, and the conspiracy theories that were generated by that fear. And as I understand it, there was, and you were involved in this, I think, in understanding community health and persuading people that this was something they ought to comply with in terms of medical instruction. Can you say a little bit about how you went about that work as a compassionate person to actually change the mindset of the communities?
Sure. And I think that's an integral part of a response to outbreaks. We call it social mobilization in public health, or community engagement, meaning engaging with the community, discussing certain public health practices or encouraging public health practices, educating populations on the need to actually access care early. With cholera, as I mentioned during the presentation, you can die within hours if you're severely dehydrated. So the challenge really doesn't consist of actually treating the disease. It's getting people to a health facility so they can be treated. And that requires a lot of communication with communities. So we had a lot of teams go out to communities and basically distribute soap, ensure that they had clean water, ensure that they knew what cholera was, how it was transmitted, prioritizing or emphasizing the fact that they needed to access care. But you do it with compassion because, in this country and in a lot of developed countries, there are a lot of individuals now that are against vaccines, and they're very educated people. And so when you're actually engaging with someone who has a view that's very different from your own, I think you have to be willing to accept and understand where they're coming from instead of trying to impose your own view, but with the purpose of trying to get them to seek care or change their behavior in order to become healthy. And this was very challenging in Guinea as well because of the cultural burial practices. I mean, it takes years to change behavior. If you've been burying your dead for hundreds of years, just because I come in as an outsider and tell you you must change, you're not going to do that very quickly. In Liberia, Samaritan's Purse had been there for more than 10 years and had established this relationship with the community. They had active programs where they did a lot of water programs, health programs, and therefore that relationship with the community enabled them to really focus on these messages that were important. And even though in the beginning, we personally had protesters in front of the treatment unit with machetes, eventually, communities were able to listen and respond in a positive way. I think it's important, again, to look through the lens of compassion while you're doing this. It's not just treatment. You're not imposing your own view, but you're thinking about the beneficiary at the end of the day and which outcome you want for them. And it's challenging. It's going to take time. It takes a lot of patience. But at the end of the day, I think it is such an integral part of a response to a disease outbreak.
Thank you, Linda, for your talk. There was a slide right near the beginning where you talked, it's on this last point you were making, about treating people with respect and dignity. And when you're coming to the point of, say, even educated people who make a choice not to take a vaccine or whatever, when is the critical point when you have to make the decision because it's not just for their personal health but the health of the community? And when is that compassionate as well as being, we just need to do this? And by doing it, you are overruling someone's individual rights to say no. How do you live with that one?
That's a very good question. There were a lot of discussions around forcing people into isolation when they didn't want to be in isolation to prevent them from actually spreading the disease. In Guinea, there were many families who wanted to bury their own dead, and they would run away to the forest with cadavers, unfortunately, and that's how the disease spread very rapidly, in addition to other factors. And at one point, there was a coordinator that was in charge of the response, and he put his foot down, and he said, if an individual hides a cadaver, they will go to jail. I think that was somewhat extreme, but it highlights, I think, the challenges in trying to protect the community by ensuring that public health measures were respected or adhered to, versus letting an individual make decisions that negatively impacted others around them. And I don't think there is an easy answer, but at the end of the day, I think looking at the greater good of communities/populations as opposed to one individual. I think quarantine is a concept that has been somewhat controversial over the years. And when responders were coming back to the US, the state of New York decided to place many individuals in quarantine. And there was a nurse who decided, I'm not going to do this, and basically rode her bike and left her house and was being followed by the police. And she said it was a violation of her rights. However, if you are in fact sick and you're at risk of actually spreading a disease, I think it's really important for authorities to make a decision to prevent the spread of disease. So there is that tension between individual choice versus the good of an entire population. And you do it with compassion, I think. And if you actually do it with compassion, it does make a difference. I would be interested in hearing from you how should Christians respond to disease outbreaks? If you're not a medical professional, what should your response be, your responsibility be as a Christian? Is everybody obligated to respond? And if you're not obligated to respond, what should your responsibility be?
Linda, here's another hard question for you, since you're standing in front of us. I quite often talk about natural disasters, and as I said yesterday, I can see what is good in earthquakes and volcanoes and floods and so on, because this earth would not be habitable otherwise. Often at the end of my talks, people will say, "Ah, yes, but what about viruses? How do viruses fit into God's world? What good are they?" And they kill people. What's your theological or scientific answer to that? What good are viruses? Why are the viruses in God's creation?
That's a very good question. I don't have an answer to that, to be honest. When you think about viruses like influenza, for example, in 1918, it killed 40 to 50 million people. And the World Health Organization just established a list of 10 priority diseases that have the ability to easily kill. And the last one is called Disease X. And it's a disease that we're not aware of, that we don't have a cure for, that might kill millions of people. I don't know what the answer is. Why did God create viruses? Or why do viruses exist? Do they bring any good to the world? I don't know what the answer is, but I do know that our response to outbreaks that are caused by a virus that can cause high mortality rates should be that of compassion. I don't know if anybody else has an answer to why viruses exist and why is there any good that viruses bring to the world.
Oh, so I'm not the only one that doesn't have an answer. It's a very common question after talks I give, anyways.
So we did talk about it yesterday. I have at least one more, and I think this is an appropriate time to bring it up, Linda, if you don't mind. We're talking about compassion. You've shared with us the situations you've been involved in with cholera and Ebola, and the fear that raises, the emotional struggles you have already acknowledged when you're making very critical decisions, clinical decisions. The whole issue of compassion fatigue. How have you approached that?
That is a hard one, I have to say, because I think there are so many crises around the world. There are protracted conflicts, like the one in Syria that has lasted for 7 years. The Democratic Republic of the Congo, where my parents are from, has been experiencing conflict for more than 12 years. And I think it's important to realize that compassion fatigue does exist, at least acknowledging that it's there. And in response to compassion fatigue, going the other way, saying, well, I am going to care, making a decision to care about these folks that are miles and miles away from you. I think it's easy sometimes to read news articles and to want to see those videos of children in Syria that don't have access to care, whose parents have died because you don't want to feel down. But I think it's important for us to continue to be aware of all of these crises, to pray for these individuals that are experiencing suffering as a result of a conflict or a disaster. And if possible, sometimes, if you can respond in one way or the other, to respond by either donating cash to organizations that are able to go out and respond. And if you do have a skill that can be used to go out there, but yes, I think sometimes the world is tired of hearing about these same countries that are experiencing these disasters over and over again. And I think Haiti is a good example because I think the world got tired of Haiti, unfortunately. And we can't because they are brothers and sisters. And it's important to hear from people that are from those countries and to understand some of the complex dynamics. We talked about corruption, poverty, poor governance, which are all issues that a lot of these countries face. And I don't think everybody is called to go to those places necessarily, but raising awareness, praying for folks that are in those countries, and doing whatever we can to help, I think, is important.
Thank you. Another aspect to that, if I can just follow up. Do you ever get fatigued yourself? What strategies have you learned to cope with that?
So I remember in the middle of the Ebola response in 2015, it became almost like a routine for me to hear about the number of cases, the number of deaths. And we would have to report these to the US, for example. And the World Health Organization would present all these figures. And I think I realized at that point that I was thinking about Ebola cases as numbers and not as individuals. And one of my mentors from residency would tell me to see patients as people. And I remember being in the middle of a coordination meeting in rural Guinea, and there was a gentleman who came in with symptoms, and he was sent home. This was a mistake. And he was brought back with his wife and mother, and unfortunately died on the way, and his mother passed away as well. And he left a wife with several children. And I think because that story was personal, and I had seen him from a distance, I realized he is not just a number. And as they were presenting his case during this coordination meeting, I realized he's not just a number. He actually had a family, and his family is going to be affected. Speaking with beneficiaries, I think, is extremely important as well. When we went to the field once, there was a woman who had lost her husband from Ebola, and she was explaining to us, she was trying to figure out how she was going to feed her kids. And I think hearing those stories helps you realize that one, you might have compassion fatigue, but then it helps you kind of go in the opposite direction and do a 180.
Thank you very much. Are there any more? Yes.
My question's actually directed almost at both of you, having listened to what you shared today. I wondered if you wanted to reflect at all on, we look at these countries and think, how can we help them? Can I flip it back and say, how can these experiences help us in the West think differently about our own life experiences, and has that affected you? I know you've come from the Congo, so has resilience anyway, but from the two of your perspectives, can I ask you both? Is that Linda first, and then?
During my first trips to Haiti, I had met a family of 4. The head of the household was a woman in her late 30s, and she had about 3 children. And she lived in one of the internally displaced camps that was established as a result of the earthquake. And her son had an illness, and we went to visit them to see if we could find a solution for him so he could actually seek medical care. And she offered us avocados. And I went into her tent and realized they don't have anything. There was no electricity, barely any food. They lived in dire poverty, and yet she was offering her avocados. And I thought to myself, she probably doesn't have much else to eat. And I tried to say no, and she wouldn't let me. And I was obligated to take those avocados home. And those avocados are very precious. And I realized the sacrifice that she made. And they would invite us to their tent for meals. And I just thought, they don't have, why can't we, we have access to more resources, have that attitude? And I learned a lot from that experience, realizing that life isn't just about material things. There's another experience in the Philippines I'll quickly talk about. After Typhoon Yolanda, Samaritans First also responded. Natalie and I were part of that response, and I went to a church on a Sunday. And we were sitting outside on a porch, and the pastor's son told me a story. So when they were hit by the typhoon, water came up to their heads, and they weren't sure whether or not they were going to survive. And the pastor's son asked him, so, Dad, what's going to happen to us? Do we have food? And he said, no, we don't have any food. It's not clear whether or not we're going to be able to eat tomorrow, but I want you guys to thank God. And he said, Dad, but why should I thank God? And he said, because we're alive. And that really struck me. That life itself is more important than what we have, and we can lose everything. But God is still there. And I think in other countries, I think people are more thankful for just being alive, not having, you know, a house with 10 bedrooms with a car that you want, but it's more about life itself and being thankful that God wakes you up every morning. So that's what I've learned.
Thank you. If I can just give my own perspective on that as you asked for it. I'd endorse everything Linda has said. And then particularly as a white Western who wasn't used to travel, actually, until I got involved with Samaritan's Purse. For me, all the work that I've been involved in and the countries I've visited, for me, I hope, has given me a huge learning curve in humility. Because it took this to impress upon me just how influenced, just what a product I can be of my culture and my white Western culture. And therefore, going to Haiti, going to New Orleans, and with the communities that I worked with there, and to the Philippines, I've met a lot of people who, on the one hand, I could say from an educational point of view, from an educational achievement point of view, have not achieved much, but whose capacity to deal with life and to live with life and with the most appalling things of life has far exceeded that of my own. So I've had a great deal to learn from my Haitian friends, whom I came to love dearly, and in all of the locations that I've worked with. We don't know it all, and what we do know, we need to learn how to apply it a lot more humbly and graciously than we do. Well, we're spot on. Thank you very much. And shall we extend our thanks to Linda?